Exactly. I have to write.
Crossing borders means cooperation between cardiologists and cardiac surgeons.
Crossing borders means to me that you dare to cross a border, that you're open to asking questions and to teach each other the difficult points in an ablation procedure like we do here in Maastricht in patients with atrial fibrillation.
I think what is particularly important right now is that we have investigation about the particular properties of the algorithms. We need more detailed knowledge about how the algorithm in itself influences our scientific results before we can come to conclusions about whether or not we should use the new techniques, the Tupera system, or also the ECGI-based systems for catheter ablation.
Cardiac surgeons have learned how to treat atrial fibrillation 25 years ago. Meanwhile, cardiac surgeons are able to treat atrial fibrillation minimally invasively. But if we try to avoid the pump, if we go for thoracoscopic approaches, we are not able to treat all lines which are necessary to get excellent results. So today there is a need that we work hand in hand together with electrophysiologists and cardiac surgeons to produce better results for our patients who suffer from atrial fibrillation.
I think a single procedure has some major advantages. First of all, it is because of the patient himself. I believe if we can propose a procedure to the patient where he only has to come once to the hospital, this of course has an important effect on the comfort zone but also on the confidence level of the patient. Secondly, for economical reasons, the patient, since he's only hospitalized once, the economical burden for the procedure will be reduced. Thirdly, I do believe that by performing this procedure in a single step, we can reduce the complication rate by combining, let's say, the best of two worlds, by combining the epicardial and the endocardial approach and thereby avoiding complications which are inherent to both procedures.
I think surgery for atrial fibrillation has come a long way. And I think that the surgeons are able to make good lesions and treat a lot of patients with their first surgical procedure. And I think that only in patients where you do not have success, there an electrophysiological procedure could be performed, but you can do that later on. And you don't have to combine that in every patient in a single procedure.
The problem with the surgeon is he doesn't know what the effect is of his ablation. And that's also annoying. Because if you don't know what the effect is of your ablation and you don't know what the values of your lesion set, how then can you tell in the future, not after 1 year, but after 5 years, why you were successful in one patient and not in another patient?
We want to be sure that we can provide the patient a safe and efficient procedure, and by providing that single-step procedure, we have the impression that we can reduce our complication rate and therefore make this procedure a safer procedure.
I've been asked to cover state of the art of catheter ablation for AFib, and I'll try to touch upon patient selection, methods, indications, results. State of the art treatment for patients with atrial fibrillation who are refractory to drug treatment. Paroxysmal atrial fibrillation is catheter ablation. This is the first line treatment for these patients. Only for selected patients who haven't tried drug treatment should catheter ablation be considered. Catheter ablation is much less effective in patients with long-standing persistent AF.
Cardiologists tend to equalize ablation strategies with catheter strategies, isn't it? So my provocative question is, why don't we consider surgical ablation in the first place as a first-line treatment?
I agree that the surgeons may be able or are able to isolate the pulmonary veins in more patients than if you do catheter ablation. I also believe that catheter ablation has improved, that we are able to isolate the pulmonary veins in more patients than we were 10 years ago. I also think that the risk of complications is at least as high or higher with surgical approach than with catheter approach.
Why don't you try to make this step, this conceptual step, to take into consideration as a community, EPs and surgeons, that maybe there is also a place for surgical pulmonary vein isolation as a first-line treatment?
I can understand that, but I also have to say it would be nice to see some well-conducted randomized controlled trials comparing the strategies and showing for us, documenting, that it is better or at least as good.
I would like to answer your question. The answer is easy, no. There is no way to perform first-line therapy on PV surgically because we do not have the data. And you have the data because you were much more clever than surgeons.
Discussion was great. Interesting whether primary or first-line treatment with surgery could ever be considered.
I presented on guided AF ablation for the surgeon, and we compared a endocardial versus an epicardial approach as it is being performed in Maastricht and in Amsterdam. We only use epicardial conformation in Maastricht to do an endocardial approach, and what we showed basically is that although technically different, both approaches are associated with the same high success level. The next question was, is this now more expensive? And just a preliminary analysis shows that yes, it's more expensive per procedure, but if you then divide those costs by the percent of success, so calculate the price per percent success, prices of all three treatment strategies, catheter, surgery or hybrid, are similar.
We still don't have any data. We have a lot of retrospective data or single center data. We don't have randomized data that really proves that the hybrid approach is beneficial to a patient in terms of having higher success rates than catheter ablation, and this is what we want to prove with a randomized trial. So it is time for a randomized trial.
There are upcoming trials comparing the new approach, the hybrid approach, with older types of interventions or treatment approaches.
We are showing new techniques, innovative techniques in cardiac surgery, minimal invasive cardiac surgery. And this is a technique that is not known or only partially known by the audience. And it is the most optimal way to show all the details and all the technical aspects that are new. And this is the perfect way to teach and to demonstrate what it's all about. Because a new technique can be important and can offer new opportunities and new cure for our patients.
Yeah, I think it looks to me a very good point. We had a similar thing in ventricular tachycardia ablation to go from endocardial and from epicardial, and I think it makes a lot of sense. I think it has a much higher success rate to do it from endocardial interventionally and then with whatever method from epicardially on top.
In this particular patient, this is the strategy we adopt. First to look what remains from the previous ablation procedures.
The absolute nice thing about live cases is that you have the time to interact not only between the electrophysiologist and the surgeon, but between electrophysiologists in the room and surgeons within the room. And that makes it a fascinating point of discussion.
We have to do it together, surgeons and EPs together. That's the future.
Out of these 40 patients with a stroke, if you have a patient with a stroke and you have the feeling this is most likely a stroke that is cardioembolic, very much likely due to atrial fibrillation that has never been diagnosed, how can we diagnose previously undiagnosed atrial fibrillation? And the answer is that all the methods from the body surface, like ECG, event recording and so forth, will not work. You need to implant a loop recorder that has a monitoring time of 90 days or 2 years, 3 years, and then you will get the whole picture of atrial fibrillation.
My presentation is on antithrombotic therapy around the procedure of atrial fibrillation ablation. Now the goal with anticoagulation is to reduce thromboembolic events while minimizing the risk of bleeds. Now the incidence of stroke and TIA around ablation for atrial fibrillation is around 1%. So there is room for improvement.
So we are opening the pericardium like this morning. So we do this a little bit higher than the phrenic nerve. Of course, we don't want to harm the phrenic nerve. Certainly, by no patient, but certainly not in this kind of patient with sleep apnea. But as you can see, in fact, for an obese patient like this, this is still reasonable. Since we're going hybrid, it's because the patient, of course, has to be heparinized, and therefore all these small bleedings are, let's say, more important than when you don't heparinize the patient. So now I'm going towards the inferior caval vein, always taking into consideration the phrenic nerve, of course. So this is the area in between the right inferior pulmonary vein and the inferior caval vein, so that the dissection will be sufficient, I think. But that's typical in the obese patient. The caval vein is a little bit more let's say pericardial. But this is the caval vein. And you can see this huge pulmonary vein here, the right superior pulmonary vein. So he has a very big atrium with huge veins. You can see that. It's much bigger than we saw this morning.
For the moment, we thank you and your team very much for having been able to be with you, and we wish you all the success.
This is a fascinating symposium, and I truly mean this because it's clear that the cooperation between the electrophysiologist and the surgeon will only improve the outcome for the patient. What I've seen today is that surgical ablation can help, especially in those patients that are prone to pulmonary vein reconnection after 1 or 2 or 3 failed endocardial ablations.
You know, the hybrid ablation is obviously one answer to a very significant and very complex electrophysiological problem. In the future we will see more studies, observational but also randomized. So we are going to start a randomized study with hybrid ablation versus catheter ablation. That sort of studies we need to really answer the question what is really an approach towards this problem, especially the persistent atrial fibrillation problem.
Crossing borders is what should be done, but you're asking someone who has already crossed that border. Crossing borders means that you have to go out of your comfort zone, start collaborating with people that have different capacities and different competences, and try to make the best of both worlds.